All right, good afternoon. I'm Rod Tarago. I lead clinical informatics for academic medicine at AWS, and today the three of us are going to talk about some really cool stuff that we think is going to be really impactful to patient care. Now, I came to AWS a couple of years ago, and before that I was a pediatric critical care physician for 20 years. In that time, I got to see some amazing things. I got to see kids come back from the brink and make full recoveries. But I also saw instances where our system wasn't necessarily functioning as well as it could. So I'm going to start you with a story. And I want you to imagine a little 4-year-old boy. This could be somebody in your family, somebody you know. But this little 4-year-old boy is otherwise healthy, but he has seizures. Now, fortunately, his seizures are pretty well controlled. He takes some medicine for them and does okay. And so this little boy and his mom, they go to their neurologist to have his regular checkup. And they look at him, everything looks good. They give mom a new prescription for his seizure medicine, give him a nice little piece of paper with the hospital logo at the top, with a list of the medications, and then send him home. And everything's going great. He's had no seizures. About 2 weeks later, one morning, his mom goes to wake him up, goes into his bed and shakes him to wake him up, and he doesn't wake up. She shakes him a bit more, and he still doesn't wake up. And after a few minutes of shaking him, she realizes something is wrong, and she calls 911. The ambulance arrives, they pick him up, they take him to the local emergency department, and when he arrives, they do all kinds of stuff. They draw blood, they do a scan of his head to make sure there's nothing going on in there. They even do a spinal tap to make sure that he doesn't have meningitis. Obviously pretty traumatic for not just him, but his mom. And about an hour later, they get the labs back, and it turns out that the level in his blood of one of the seizure medicines is toxic. Essentially, he overdosed on his seizure medication. And everybody's sort of wondering why, because his mom shows him the bottle and said, this is what he's taking. So they look back, and she reaches into her purse and pulls out the list of medications that they gave her at the last visit. And she says, look, here it is. So they start looking at the medication list, and it turns out that when the neurologist refilled the medication, he had changed it from a generic to a brand name drug, but it hadn't removed the old one. So this mom was giving him exactly what was on this list. She was giving him twice as much as he should have. And as a result, he overdosed. And all of this stuff that happened was because of that single error on that medication list. So this is an example of a preventable medication error, preventable error that we see in healthcare. And unfortunately, this is all too common. Now, when I went to medical school, one of the first things we do when we go to medical school is we take the Hippocratic Oath. And part of that Hippocratic Oath is primum non nocere, which means first, do no harm. Now, while we've made a lot of progress since the times of Hippocrates, we still see way too much harm in healthcare. Patient safety really sort of came to the forefront in 1999 with the publication of To Err is Human by the Institute of Medicine. And for those who haven't read it, it was a very comprehensive report looking at patient safety in the United States. And in that report, they estimated that up to 98,000 people in the United States die every year from medical errors. It could be medications, it could be all these other things. Almost 100,000 people a year. That was almost 25 years ago, and we've certainly made some progress. But as recently as this last January, David Bates and some colleagues looked at inpatient hospitalizations in the US, and they found that 1 of every 4 patients undergoes some type of harm from patient safety errors in this country. 1 out of every 4, 25%. So you go into the hospital, there's a 1 in 4 chance that something bad is going to happen to you due to an error. Now that not only affects outcomes, but it affects costs. Every time there's those errors, that prolongs hospitalizations, that causes other procedures to happen. So That's a problem. And when you look at how we're doing in this country compared to other countries, it's not very good. This is the Commonwealth Fund. They come out with their mirror report every year. And ideally, you want to be up high. That tells you that you're having really good outcomes for lower costs. Notice where we are. We're in the lower right. We have a very, very expensive healthcare system with not very good outcomes. So it's a problem. And we need to look at new approaches to addressing this. Fortunately, unless you've not been looking at the news at all, we do have some new opportunities. Artificial intelligence, including generative AI, offers us some tremendous opportunities to look at these things in a different way. But we have to do it carefully. Now, when we talk with healthcare organizations all over the country, there's lots of different options for use cases in healthcare. We can use generative AI to help researchers query data more effectively, more efficiently, and easier. Maybe they don't have to go to the data scientists anymore. We can help clinicians take all of this administrative work that they're unfortunately used to doing now and automate that. We can help summarize information so that if I'm a referring physician and I'm getting a 100-page PDF, I don't have to go through it manually. I can do it electronically. Lots of different opportunities. But we still have to look at that end goal in mind. This is the quadruple aim. That really is the basis for what we do in healthcare. We can use artificial intelligence and work backwards with the goal of improving our outcomes, reducing our cost, and in the process, making the lives of the patients and the clinicians better, all while having this foundation of fairness and equity. So, with that in mind, it's my pleasure to introduce Chad Vandenberg. He is the Chief Quality and Patient Safety Officer at UC San Diego Health. We've been working together on some pretty innovative stuff in using artificial intelligence to improve patient safety. He's going to walk through their journey at UCSD with AWS, how they have used artificial intelligence to this point, and then how we're looking to do it in the future.
All right. Well, thank you, Rod, and thank you all for being here today. I walked in this afternoon not knowing exactly what I was walking into, and it's a world filled with innovation. It's audiences like this through many, many casinos trying to figure out how do we improve the world we live in. So thank you for being here. Thank you for the opportunity to share some of our story with you this afternoon. So I'm going to share a few things, some examples on how we're using the technology, how we plan to use the technology. The underlying sort of approach that we are taking is everything must be operational. Everything must be seamlessly integrated into clinical workflows. We can't have our providers spending any more of their precious time having to go outside of the systems they're ordinarily working in. And it has to have a fundamental impact on that quadruple aim that you heard about earlier. So our Chief Medical Officer and Chief Digital Officer, who is actually on his way to testify in Congress around healthcare AI, has been quoted as saying that AI could be as impactful as the introduction of penicillin. And I think that when we look back on this time, I think we're all going to agree, because we are, in my opinion, on the precipice of fundamental shifts on the way we approach healthcare, and in my world in particular, the way we approach quality and patient safety. So the University of California has a long-established relationship with AWS. We're partnered in a whole variety of ways. But UC San Diego Health is looking to push that envelope even further. We're trying to figure out ways, again, to leverage the technology to improve the outcomes for our patients. We believe that with the technology, we're going to be able to do some things very differently in the future. And I'm going to show you a few of those examples here today. There's a lot of quotes out there around AI, and as we were sourcing some of those to put on the slide here today, I chose this one because there are some fears associated with AI. We have to be cognizant of what are we getting ourselves into, and so there's been a lot of talk about replacing jobs with AI. And I truly believe that the future is not about replacing jobs, but by putting the technology in the hands of those who can use it more efficiently to drive better outcomes for our patients. So I'm going to tell you a few stories. I think you're all familiar with this little thing we went through called the pandemic. We had the second plane carrying evacuees from Wuhan land at the air station just north of San Diego at Miramar in February of 2020. This, for us, ultimately led to us caring for one of those very first patients in the country. And what that did for us is, and I'm sure for all of those in healthcare, is put us on a pace of change that we had never seen before. We were forced to innovate, then to integrate that change at a pace and a scale that I don't think we had seen, or certainly not in my career, my 27-year career. And what happened with this patient who arrived, like many other healthcare systems who ultimately cared for patients with COVID, we spun up a command center. We had leaders, including our clinicians, our pharmacists, our nurses, our physicians, in the command center, thinking every day about how do we care for that next patient in a new, innovative, better way than we knew how to the day before. So we had to deeply, deeply integrate informatics into this equation. So every day, truly every day, our dashboards were changing. The technologies supporting those dashboards were changing. We were bringing to bear data to help inform that next day's care. And one example from this is the way we leveraged and then brought to scale an AI algorithm that one of our physician scientists at UC San Diego Health had developed. He had developed an algorithm focused on detecting pneumonia through the use of AI and image recognition. The challenge that we had very early in our journey was that we had that algorithm on a desktop. It wasn't deployed widely. We weren't using it widely. But through some conversation, through those discussions at our command center, it quickly became apparent that this technology that this provider had developed would be useful, very useful for us, certainly in those early days in detecting COVID. So we quickly spun up some support, partnered with AWS, began taking those images, sending them out to the cloud, applying the AI algorithm, and bringing it back to our providers in less than a minute. Again, there will be a theme through my conversation with you this afternoon, which is integration into workflows. We can't have our precious time spent going elsewhere. So we had to bring those images right back into the place where our providers will ordinarily look for them, and then see what this technology could bring to bear. And it was that innovation at scale that allowed us very early on, and I apologize, I'm gonna take a quick sip. Very early on, detect what we suspected to be COVID. And if you recall, in February and probably even in March and parts of April, testing wasn't really ubiquitous. We didn't have a lot of testing capability. We had a lot of treatment things that we were trying to do, but we didn't have easy access and robust access to testing. Now that changed pretty quickly. That was part of the innovation and the pace of change early during the pandemic. But this algorithm allowed us, through incidental finding and sort of direct inquiry, to detect those patients who were likely to have COVID. And then, of course, we could get them into care, begin the treatments and therapies that were necessary to sustain their lives.
All
All right. So staying with that, I want to talk a little bit about impact, because again, and I probably will be shamed for saying this here, technology for technology's sake is maybe another toy for the shelf, maybe another opportunity to bring some innovation, but without the impact to provider workflows, without the impact to the care we're delivering, and certainly without the impact to the patients for whom we're delivering that care, this is kind of a fun exercise, but not one that's going to fundamentally change what we heard at the start of the presentation this afternoon, which is 90, and that number has actually grown with some of the newer studies, but it will say at least 100,000 lives lost to healthcare every year. And that's what drives us at UC San Diego Health. So impact. So this was some work by Dr. Demeff, Dr. Carlisle, who wanted to study, now that we were bringing this technology to bear, what kind of impact was it having? We knew we were getting folks earlier into treatment, but was it affecting our clinicians' decisions? And in fact, it was. About 1 in 5 of our providers attested to changing their clinical decision or changing the clinical direction and care for our patients based on the algorithm. So this is actually an image of what comes back on those radiology exams where the lungs light up based on the algorithm. I remember very early in February, March, walking through our ER, talking with our providers, talking with our nurses, and having conversation about that uncertainty that we were living in with the next patient who was arriving. And them showing on their desktops, hey, look, we have one here, right? Pulling up the image, visually being able to detect this early, again, changed lives, certainly for our patients, and got them earlier into care. But it's about outcomes, right? It's about that care and impacting the quadruple aim. So there are, and were, and probably continue to be, lots and lots of articles in healthcare talking about the use of AI during the pandemic, specifically with COVID-19. Thousands. This was in March, I think, when we pulled this statistic here with over 9,000 articles mentioned, but only 4 of them spoke directly to the clinical outcomes that they impacted. And this is what motivates us at UC San Diego Health. We are on the active pursuit of that next thing that will allow us to directly impact the outcomes for our patients. All right. So we are very fortunate that we will be able to amplify and scale that impact. Certainly partnering with AWS and others, at the great generosity of Joan and Erwin Jacobs, and under the direction of our Chief Digital Officer, Dr. Longhurst, we are able to stand up what we are calling the Center for Health Innovation. And its entire pursuit is to find these technologies and these innovations that will have an impact on outcomes, have an impact on the patients and the lives for those we're privileged to care for at scale. This is not about nipping at the edges, which if I were to be frank, I feel like we've been doing for 20 some odd years. This is about having a true seismic shift in the way we're delivering care to have an impact on that quadruple aim. Really impacting our provider experience, our patient experience, the cost in which we're able to deliver that great care, and certainly the outcomes for our patients. So I'm going to give you a few examples of how we've deployed some of this technology, and again, with the underpinning of how do we do it within the workflows in which folks are already operating it. How do we do it so that we can demonstrate impact? How do we do it so that we're making fundamental shifts in the way we're delivering care for our patients? So the first example I want to give you is our work in sepsis, and I say our, let me give the credit where credit is due. Dr. Wardy with a data scientist, Dr. Shamim Namadi, worked together on a iteration of an AI sepsis algorithm. If any of you are in the direct healthcare space and you use Epic, and it's probably true with Cerner and many other EHRs, there are embedded algorithms already for some of these high prevalence diseases, sepsis being one. But what we found with this embedded algorithm is that it was alerting way too often. It wasn't as sensitive or as specific as we would like. It wasn't, in our case, leading to change in the way we were delivering the care, which again is the underpinning of the way we're going about all of our quality and safety work. It must do that. So they developed this algorithm, iterated on the algorithm, and one of the sort of key fundamental aspects of the development of the algorithm is to teach it to say, I don't know. To actually allow it to not have to deploy a fire or an alert every single time. So when in a space of uncertainty or when it is not at the degree of confidence that we would like, it doesn't fire, which is great because I'm sure you all have all heard about alert fatigue. And as we think about that quadruple aim, and we'll keep bringing us back to that, the provider experience, our nurses and our physicians don't want to see a bunch of flashing alerts that may or may not influence the way that they're going to deliver care. And we see a lot of those, although we monitor them and then begin to turn them off at UC San Diego Health, but we see a lot of them where folks are just like bypass, skip. So it's important that when we develop the technology, that we develop the algorithms, like in this case, that it's actually something folks are going to react to. And so this ability to teach the algorithm to say, I just don't know, I don't think this is a time to fire, was a critical piece of the success here. The other really important part of this project was this pairing of a data scientist and Dr. Namadi with a practicing physician in our emergency department, although he's board certified in emergency department and our emergency care and critical care, and an incredible physician, Dr. Wardy. But that partnership was immensely invaluable. And then when you layer on a nurse partner from our quality and safety team who was there to work by their sides to say, now that we think we've got the algorithm right, what does it look like in application? What do we do with it? Where do we fire it? When do we fire it? Who sees it? How does it come through? The way we deployed this sepsis algorithm is we're starting in the emergency department, and the outcomes you're seeing are from that deployment, where it fires in the emergency department to our nurses, not to our physicians. So our nurses are often the ones who are doing the bulk of the documentation of those vital signs and other things that are going to be key to the alert for sepsis. They get that initial alert right in a way that they are enabled to take action out of it. So that action is actually the ability to securely message our physician. So they can go right from an alert to talking to the physician around the patient. Hey, I've got this alert. Here's the clinical picture of the patient. How should we proceed? And of course, the care proceeds in a way that is evidence-based and has led to some pretty significant results. Probably the most important for our patients is we've seen a significant decrease in sepsis mortality. So early intervention, because of the alert firing, because our nurses and physicians are taking action on the alert, we're seeing an actual decrease in mortality associated with this disease. The second impact associated with this algorithm is the ability to evidence that we are following evidence-based care. And that is through the completion of the SEP1 bundle and making sure all elements of the bundle, getting the lactases, getting the antibiotics on board, et cetera. So again, the physician partnered with the data scientist, thinking about how do we seamlessly integrate into our workflows to demonstrate impact. Another example of our use of technology and AI, in this case generative AI, is with our approach to the inbox fatigue. Our providers like others at healthcare organizations, get hundreds and thousands of these inbox messages from our patients. Critical opportunity to sustain that physician-patient relationship, certainly helps our patients course correct on their care, maybe avoid having come into the emergency department or other visits. That mode of interaction we think of as very precious. But it's precious at a cost, and the cost is our provider experience and provider experiences across the country. We know that most of the time spent responding to patient messages is what we call pajama time. So this is the time where our providers should be going home, perhaps enjoying some time with their families or friends, and then getting a good night's rest to repeat the immense care that they provide to our patients. But what happens when we ask them to maintain that relationship with their patients in this way, they're often doing that at, either when they get home, right after they've put the kids to bed, or maybe deep into the evening, again, taking their precious time to sustain that relationship. So we said, is there a different way? And you may have seen some of the headlines. I don't know if we have them here. We don't. But some organizations decided that the way to curb some of this was to begin charging patients for these messages. So looking at it as though it were an encounter. And there's been some success at curbing that. For us, we felt like that might jeopardize that relationship with the patient. So we wanted a different way to approach it. Ways that would benefit the provider and the patient. So the one for the patients may be perhaps the most obvious. We don't charge them for these interactions. The one for the provider is we're trying to make it easier and easier to do this. So we started in our primary care locations, have begun to deploy it in other parts of our ambulatory environments. But to be able to leverage technology, generative AI, to look at the message, contextualize it against the medical record of that patient, and then respond with a appropriate sort of draft for the physician to edit. So instead of them having to create it de novo, they're getting something to respond to. We're optimistic that ultimately, and we haven't realized that quite yet, but ultimately this will save them time. This will be better for our patients and enable, again, that continuation of the relationship. So one of the interesting things from this, I think if it's on, yes, the next slide, is there were a lot of headlines about this, and there's some studies around, the capabilities of generative AI to generate these responses to our patients. One of the more sensationalized headlines said something like that these responses were more empathetic and of higher quality than our physicians' ordinary responses. We interpreted that study a little bit differently. We think that given the time, our physicians, and the data suggests this, given the time, our physicians would absolutely generate the same kind of high quality, empathetic response. But as I started with, they're doing this deep into the evening after a long shift, perhaps with whatever pressures or stressors they have at home, deep into their pajama time. So what we seek to do is to cut down on that pajama time, enable them to do what they already would love to do, which is to generate a empathetic, complete, high-quality response to our patient questions, but to do that in a way that takes them absolutely less time. So we have much to do still here. And I think that's another thing as we get into these kind of conversations is to appreciate that this is not going to be we're going to put it in place and grand slam, or whatever your other sports analogy will be. We have to iterate, and we're going to have to learn, and we're going to have to iterate, and then we're going to have to learn, and then we're going to get better and better at this. The technology will help us do that. We see that our patients equated a longer response to their queries as a higher quality response. Okay, so how do we use the technology to try to, again, maybe shift that a little bit. Maybe we can get a little bit shorter response, but still have it be seen as high quality, again, leveraging the technology. How do we, again, chip away at the time that the physicians are editing these responses, make the response that is generated for them of higher and higher quality? And then again, try to mitigate that editing. So they are still editing, right? We don't ever just send the response. The physician has to take an active step. Because we know we're early in this pilot, we knew that was a necessity for the quality of the care we were providing. But again, what our goal is to cut down on the amount of editing they're having to do, right? So that they can see the response, the drafted or crafted response, and have, I'll say, less interaction with it, but still make sure it's what they would want to do in terms of a response. Let me shift gears just a little bit and talk about large language models, because for me, when I thought about this presentation, I saw the slides that Dr. Tarago presented earlier, and then thought about my own 27-year career. We haven't made the kind of dent that we all want to do in terms of providing safer and safer care. Have we gotten better? Of course. Have we mitigated errors along the way? Of course. But have we eliminated them? No, we have not. Will we ever eliminate them? I don't know. I'd love to keep shooting for that. And I think about the capabilities of large language models as a pathway for us to pursue that. So let me tell you a little bit about my team. My team, like most quality and safety teams, is responsible for responding to incident reports, doing all of the quality public profile reporting to CMS, Joint Commission, and otherwise, supports peer review, examines incidents that happen in our organization, again, looking for root causes to mitigate them, works with our physicians and nurse and pharmacy partners to look at ways to implement care that mitigates variation and improves outcomes for our patients. That work today is very manual. I say, without sort of precision, but probably good broad stroke, that half of my team spends at least half of their time looking in the electronic health record for an answer. Whether that's an interpretation of the care we provided, whether that's a piece of evidence that we gave the drug at a certain time, or is it what was the sequence of care? We have to make sure we can publish our performance for folks like CMS and Joint Commission. We spend a lot of time looking in that record to, again, find an answer or evidence the care we provided. That's not even accounting for how much we spend on other partners outside of our organization abstracting records for us, because we also do that. So I think that of large language models as really the ability for our teams to synthesize what is still in the electronic health record. At over 90% of the record today is unstructured text. It's notes, it's pharmacy, nurse, physician notes, it's nutrition notes, it's all sorts of notes, unstructured text. And the promise, in my belief, of the large language model capability is that we're going to be able to significantly cut down on the time that our team members are looking for those answers. And then what we'll do with that time is that we'll redeploy all of that talent back to the bedside. We're going to equip them with the technology of understanding what's happening based on scrubbing the medical record, deploy technologies that will allow them to round with our providers with the understanding of what happened yesterday that might influence tomorrow or today, as opposed to what happens today in quality and safety worlds is we often wait for a report, then we have to analyze that report, and we're often very much looking in the rearview mirror about what happened. and the capabilities of being able to read the record, read this text, this vast amount of text, and then present back that information in a summary format with critical pieces of data is, in my opinion, why I think we're on the precipice of really fundamentally shifting the way we approach quality and safety in healthcare, because we're going to be able to respond to information guided by clinical decision. The graphic here is that it's the person with technology that's going to be greater than the person. It's not the technology alone. It's the person using the technology. And again, I think that we are on that precipice of fundamentally shifting the way we're approaching this space. Just doing a quick time check and making sure I'm on pace. All right, let me share one more example and then turn it over to my colleagues. So one other example of how we're thinking about leveraging technology and in partnership with AWS is I mentioned those incident reports that our team is responsible for. So this graphic is a graphic of by week how many incident reports are submitted, some general categories related to those incident reports. And then the real question is, and then what do we do? We have 293 in this last week on the slide. What do we do with that data? Well, our vendor partner for our incident reporting system helps us a little bit by giving data and some graphs and some charts over time. But what it doesn't do is read those reports. And as I said earlier, it's a very manual world we live in today. So we have team members who are reading all 293 of those reports. And by the way, we're encouraging more and more reporting. It is through this reporting that we're understanding what are the root causes, what are the processes, policies, or practices that are failing our providers or failing our patients. So we're encouraging this more and more. But somebody is reading each and every one of these. And then somebody is interpreting that data, somebody's bringing back graphs and charts and looking at, okay, what are the areas that we need to go pursue, again, with very precious performance improvement resources. So the promise of the large language model and the partnership we have underway with AWS is to test the ability to read each and every one of these, to bring summary information back to the same people who are reading every word today, but allowing them to do quicker interpretation, quicker sort of assessment of relative significance, and then, most importantly, reacting to it. So what we're testing is the pre-read and the categorization of these incident reports, again, thinking that ultimately we'll be able to save that precious piece of time to redeploy resources. The goal here is not to respond to incident reports. So we think that there is technology today that uses triggers. You can embed them in your electronic health record. If a sequence of steps has happened, it will alert you. You can embed these. This IHI has published on these triggers for some time. You can embed triggers in your EHR, but those are all still events that have already happened. Somebody has documented that a sequence of things has happened, and then the alert goes off. That's often what you see in these reports, is somebody said, oh, something has happened or something's about to happen, and I want to prevent that. Where I think and why I'm so bullish in this space we are going is that, and if you think about and Dr. Tarago shared a tragic story to start our conversation this afternoon. Those kind of incidents are seen as, in the medication safety world, there's a categorization scale of A, where no event, no deviation, if you will, through ultimately death. And it's a scale, alphabetical scale, where A and B are events that either didn't reach the patient or reached the patient with minimal harm. And where I want us to go and where I think we can go is to leverage the technology to understand the patterns of care in such a way that we can actually detect those A and B incidents of harm. And that is, I think, a ways off, but it's what we are passionate about striving for. It's about the prevention of harm instead of reacting to harm. And the more and more we leverage the technology, the more we understand the processes that are underpinning these events and the failures in our care processes, the better off we'll be able to prevent them and certainly detect them much earlier. So with that, I want to thank a few folks. I want to thank my partners here this afternoon who will be presenting to you all. I want to thank you all for being with us. I want to thank the Jacobs who have graciously funded our Center for Health Innovation, and for my team back at the office doing all the hard work while I get to share our experience here today. So with that, I'll turn it over to John.
Okay, great. Thank you, Chad. Appreciate it. So let's go ahead and talk about what we're building at UCSD Health. And my name's John Apiz. I'm the Senior Solutions Architect actually supporting UCSD Health. So let's talk about that architecture. So we start off, this is the general architecture here. On the left-hand side, we have two different data sources that we're working with. We're working with the Epic, which is the electronic health record system that UCSD Health uses. And then we're also working with RLDatix, the patient safety system. And so with the Epic data, we have several 100,000 patient records that are actually stored in that system. And in the RLDatix patient safety system, we have different incident records that that Chad just spoke to a little bit earlier that are recorded in the system. And so both of these data sources actually have structured and unstructured data inside of these that we want to capture. So the first thing we're doing here is we're doing a bulk extract, a fire extract from the Epic electronic health record system into S3. And then in parallel to that, we're doing a bulk export of data from the RLDatix database into S3. And we're staging both of those sets of data so that we can consume them later on in the process here. The next thing we're doing is we're leveraging AWS Health Lake import jobs to ingest the data, the Epic Health data, from S3 into a Health Lake data store. And so our Health Lake data store is our HIPAA-eligible service that helps you to do clinical data ingestion, store the data, and actually do analysis, all using the HL7 specification, fire specification. And so from here, what AWS Health Lake is doing is it's using two different services. It's using AWS Lake Formation, which is our fully managed service that helps you to create, maintain, and secure data lakes. And then it's using the AWS Glue service, which is our serverless data integration service, which helps you to catalog, modify, move, and integrate data into our Health Lake. And so in the portion of having to integrate the data into our Health Lake, we have to take our RLDatix data and integrate that into our Health Lake so that we can pair it up with our electronic health records that we've imported from Epic. And so what we're doing is we're using Lake Formation and we're using Glue to create a database table to store that RLDatix data in our Health Lake. And essentially what we have here now is we have a joining of both the electronic patient records and the RLDatix patient safety records. And so now we can query those both together using a unique identifier like a matching patient identifier. And so we have the data staged here now. And there's a few things that we need to do in order to progress that data forward and be able to be used by our generative AI application. And so the first thing we need to do is we need to convert the unstructured data, all the notes that Chad was speaking about earlier, to embeddings. And embeddings are mathematical or numerical representations of text in the form of vectors. Once we have those vectors or those embeddings, we have to store them somewhere. And with the amount of data that we have here, we have to be able to do this in a very efficient way. So what we do here is we have the data staged, like I said. We're going to use a SageMaker processing job. And that SageMaker processing job is going to take that data and run it against our Amazon Bedrock service. And our Amazon Bedrock service is hosting the Amazon Titan text embeddings model, which we use to create those embeddings. And so once we have those embeddings, we'll retrieve those. But let me pause there for a second. What that SageMaker job is doing is it's actually running on a cluster of nodes, right? We're dealing with large amounts of data, and we want to make sure that we can do this efficiently. And so we have the data distributed from the S3 bucket across multiple nodes so that each node can access subsets of that data. And then on top of that, within the actual nodes themselves, we're actually running scripts that are working through creating these embeddings. And those scripts are using Python parallelization in order to add another layer. So we have parallelization at the cluster level and also at the node level. And so again, we've run the data through our unstructured data through our Bedrock service. We are now retrieving embeddings back from that. And then our SageMaker processing job is receiving those embeddings back and then passing them on to store them. Along the way, before it actually stores them, it acts the structured data to our embeddings as metadata so that we can store that in OpenSearch. And OpenSearch is our distributed search and analytics service. And in this case, we're using the nearest neighbor plugin enabled in OpenSearch in order for us to be able to do similarity searches in our OpenSearch database. And so one thing to note here is with AWS, you have your choice of many different services that you can use. So in the case of a vector store, you have the ability of choosing things other than OpenSearch. You could do Aurora Postgres SQL with the PG Vector extension. You could use our serverless vector data store through OpenSearch as well. And there's probably a few extra announcements too coming out if you haven't seen them already. But essentially, you're able to switch out any type of service that you need to use for the vector data store. And so it's important when you're doing this kind of work and you're trying to find the right tool for the job that you keep your embeddings and your data close to each other so that you can experiment. Because A, you want to save on time. You want to make sure that the ingestion of this data, of the creation of the embeddings, is performant and is scalable, especially with hundreds of thousands of records potentially that you're going through. So let's go ahead and proceed here. So I said we have all the embeddings already stored in the vector data store. And so now we have our application on the right-hand side. And the application is a chatbot interface that we're using so the UCSD health staff can interact with the data that we've stored. And so essentially what's going on, it's just three different components of this. It's a web application. There's the API gateway that's backing that. And then the API gateway will invoke a Lambda for us. So what the user does is they input their question in through this chatbot interface. And then it gets passed to our API gateway. And then from there, it gets passed to our Lambda. And so what the Lambda is running, it's actually running a framework called LangChain. And it provides us with very flexible abstractions to different types of resources that we can use, and also different types of tool sets that we can use. And essentially, this is a space where we did a lot of work because we have to figure out what types of interactions we want to have with our large language models later on in the process. Which data stores we want to connect to. In this case, we're using the OpenSearch vector store, right? So there's a lot of different pieces and flexibility within LangChain that you can use. Do we want to use agents? Are there tools we want those agents to be able to use in order to be able to interact with the large language models in a specific way? So there's lots of variation. We did a lot of experimentation there. This is also a place where we're passing the hyperparameters potentially to different models and making sure we're fine-tuning those hyperparameters in a way that actually make this process efficient and then return some data back. So now that the Lambda has the user question, we're going to go ahead and pass that on back to our Amazon Bedrock service. And we're again using the Amazon Titan text embeddings model in order to be able to retrieve embeddings from that user question for us to do the similarity search a little bit later on. Again, this is the same model that we used with the original data source so that we could make sure to be consistent with our response back for embeddings from this service. So one other thing I forgot to mention is when you're dealing with a chatbot, you have a conversation history too that you have to maintain. So that is actually being stored in DynamoDB, which is not in this diagram. So now that we've passed the input, we're going to go ahead and have those embeddings retrieved back by our Lambda. And then we're going to take those embeddings that we've received back from our Amazon Bedrock service, and we're going to go ahead and pass that on to OpenSearch. And we're going to take and initiate a similarity search using those embeddings to see what other embeddings are close distance using the nearest neighbor algorithm to the embeddings that we're looking for. So we're looking for what's the most similar embeddings that we can find in our OpenSearch vector store. And so from there, OpenSearch sends back to our Lambda. Again, this is using LangChain to enable that connectivity back and forth. OpenSearch returns back all the similar data that corresponds to the questions that the end user actually put into our chat interface. And then we take that data, we generate a prompt from using LangChain from that prompt, and then send that prompt back to Bedrock. And then from that point on, what we do is we are leveraging Anthropic's Claude V2 as our large language model, and then passing it that prompt, which is, again, the user question and all the similar data that we retrieve back from OpenSearch. From that point, Bedrock returns back the generated response back to our Lambda, which is then sent back up to our end user. And so you can see that this allows our end users to be able to interact with very large amounts of data in a chat interface to surface up some of the things that we talked about that could improve or have an impact on patient safety. And so from there, we can start to fine-tune and figure out different ways of changing different components. So like I said before, another thing we're experimenting for our vector database is actually PostgreSQL as well. So I encourage you to take a look. There's many blog posts on that we could share with you afterwards that actually have different components of this. And I want to thank you very much for your time. Let's go ahead and hand it off back to Rod. Thank you.
All right, so you've seen how John does it, but I started this talk today with asking you to imagine, and we talked about a case. Now I want you to imagine Chad's life 6 months from now. Right now he comes in the morning, and he and all of his staff are getting stuff via email, they are pulling it into Excel, they're building pivot tables, and they're doing all this manual work. But just imagine if they could come in, and whether by typing or by voice, start just asking the system question. How many things happened last month? How many events happened last month? How many of those events were related to high-risk medications? Tell me more. Were there any trends? And so putting that into an interface that is intuitive and informative and allows them to dig further. So how many events occurred? Who reported them? How many involved opioids? Write me a report for that. This is really cool, but I think this is not what's going to fundamentally change what we do in patient safety, as Chad mentioned. What's going to fundamentally change what we do in patient safety is not tell me all the patients that had an event last month. It's look at my hospital today and tell me which patients are at highest risk for one of these things and why. Why? I think that's the key thing. Because you can say, yeah, these 17 patients are at risk for something, but what do you do with that? We don't know. But if we can really start digging into it and finding trends, finding risk factors, and doing it in a way that is intuitive and easy to use so that anybody, a charge nurse in an ICU can say, who really are my sickest patients based on all of their data? That's, I think, the really exciting part. So before we finish up, I want to encourage all of you to complete your evaluation in the reInvent app. That's the data that they use not only to grade us, but also to argue for more healthcare sessions next year. The other thing I will encourage all of you to do, we talk a lot about the technology and what we're doing and generative AI and things like that, but in the end, it all comes back to the why. And I started at the beginning with the story of a little 4-year-old boy. One of the projects that I am really humbled to be part of is we are working with the Children's Brain Tumor Network, which is a collaboration of about 30 hospitals whose goal is to eradicate pediatric brain tumors. And it's one of the only sort of standalone organizations that we've been working with who has been really heavily involved with us. So much so that if you go to the healthcare area, this little girl, Cameron, designed a pin for us. And so if you go to the healthcare pavilion area and say, I want the CBTN pin, it'll be a pin that she designed for us. This is a project that we hope, right now, if you're one of these pediatric institutions, from the time that a patient is seen to the time that that patient's data gets into the shared network, it's about 6 months. Our goal with this is to get it down to 6 hours, and you can just imagine how quickly people can learn about this. So I encourage you to go do that. And then I mentioned the Healthcare and Life Sciences Expo. We have tons of resources, demos, including generative AI demos that are specific to healthcare there. So if you have time, I encourage you to go there. Chad and John and I are going to be down here at the bottom right answering any questions that you might have. So I encourage you to come up. And with that, I thank you so much.